Welcome everyone to the Orlando GI Journal Club. This is November 6th, 2024, 7 a.m. Eastern Standard Time, and we're coming to you from Orlando, Florida. Our first study is by Tivethia et al. This was a randomized trial looking at the combination of carvedilol with variceal band ligation in the prevention of first variceal bleeding in child Turcotte B and C cirrhosis with high-risk esophageal varices. Prevention of first variceal bleeding is the most appropriate strategy to reduce clinical decompensation and bleeding-related mortality. Non-selective beta blockers and endoscopic variceal band ligation are mainstay for prevention of variceal bleeding, especially for medium to large esophageal varices, and are effective in prevention of variceal bleeding and reducing bleeding-related mortality in compensated cirrhosis. However, in decompensated cirrhosis, there is limited data on the choice of beta blockers versus variceal band ligation for primary prophylaxis. Also, there is limited data on combination of both beta blockers and variceal banding for primary prophylaxis of variceal bleeding. The aim of this study was to determine the efficacy of combination therapy compared with monotherapy in the prevention of first variceal bleeding in advanced cirrhosis. All right, so this was a randomized trial. This was a single-center study from India. Patients aged 18 to 75 years with child Turcotte class B and C cirrhosis and large esophageal varices, so greater than 5 millimeters in size, or high-risk esophageal variceal or high-risk esophageal varices, such as those having red spots with no prior history of variceal bleeding, were enrolled in the study. Patients were randomized into one of these three groups: carvedilol monotherapy. The investigator started at 3.125 milligrams BID, and then the dose was escalated weekly to achieve maximum tolerated dose with a target heart rate of 55 to 60 beats per minute, or until there was at least a 25% decrease in heart rate from baseline. Or the patients were randomized to variceal band ligation alone, which was conducted every 3 weeks until complete eradication of varices. And the third group was combination of carvedilol with variceal band ligation, and carvedilol was started on the day of the endoscopy. The patients underwent a 1-year follow-up, and the primary outcome measure of this randomized trial was the incidence of first variceal bleeding at 1-year follow-up. 110 patients were randomized to carvedilol alone. 110 patients were randomized to variceal banding, and 110 patients were randomized to combination of carvedilol with variceal band ligation. As you can see, these are the demographics for the patients. So the mean ages were 51 in carvedilol group, 50.6 in band ligation, 52.3 in the combination group. The most common etiology for cirrhosis was fatty liver disease and alcohol. When looking at other comorbidities, diabetes and hypertension were the most common coexisting comorbidities. And if you look at the baseline hemoglobin, there was no significant difference across the board. And here you can see the MELD score of 15.1 for group with carvedilol only, 15.3 for band ligation only, 15.1 for combination therapy. This is the CPT score, 8.8, 8.9, and 8.9 for carvedilol, band ligation, and carvedilol, respectively. This is the incidence of first variceal bleeding when comparing the three groups. So when the investigators compared carvedilol with band ligation versus carvedilol only. As you can see, the incidence of first variceal bleeding was significantly lower in the combination group at 11.8 compared to 33.6% for carvedilol only. When comparing carvedilol with band ligation, again, the incidence of first variceal bleeding was significantly lower compared to band ligation only, where the incidence of first variceal bleeding was 25.5%, and that was significantly lower in the combination group compared to band ligation. When comparing carvedilol with band ligation only, there was no significant difference between the two groups. The authors also looked at the survival rate over 12 months, and as you can see, at 12 months, the survival in the combination group, carvedilol with band ligation, the survival was 93.6% at 12 months, and this was significantly higher than both carvedilol alone, which was survival of 80%, and band ligation only, which had survival of 85.6%. When comparing survival at 12 months between band ligation and carvedilol, there was no significant difference between these two groups. The authors also looked at time to bleeding and also mortality, and they found that the combination of carvedilol with band ligation mortality was 6.4%, for carvedilol only was 20%, for band ligation only was 14.5%. And again, the mortality at 12 months was significantly lower in the carvedilol with band ligation group compared to both carvedilol and band ligation therapy alone. When looking at time to bleeding, again, it was significantly longer in the carvedilol with band ligation group compared to monotherapy of either carvedilol alone or band ligation alone. However, when looking at time to mortality, the rate of liver transplantation and need for TIPS, there was no significant difference between carvedilol with band ligation versus monotherapy with either carvedilol or band ligation. The authors also looked at the incidence of liver-related events, and there was no significant difference between the three groups when looking at the incidence of worsening ascites, change in diuretics dose, onset of acute kidney injury, and SBP. As you can see, the rates were pretty similar for these liver-related adverse events between the three groups. The limitation of this randomized trial was that there was no blinding due to the different nature of the treatments undertaken, and non-invasive testing, including transient elastography and CT, were not performed in all patients. The take-home point from this randomized trial is that in child, Turcot-Pugh, class B and C cirrhosis patients with high-risk varices, combination of carvedilol and variceal band ligation was more effective than either therapy alone for primary prevention of variceal bleeding. Therefore, combination therapy of portal pressure reduction by carvedilol combined with esophageal variceal ligation is recommended in these patients. Our next study is published by Choi et al. This was published in Lancet Gastroenterology and Hepatology. This is an open-label, multi-center randomized trial comparing intensified versus standard dose Infliximab induction therapy for steroid refractory acute severe ulcerative colitis, the PREDICT UC study. Acute severe ulcerative colitis is a medical emergency with associated risk of emergent colectomy and mortality rate of up to 1%. Corticosteroids are first-line therapy for acute severe UC. However, approximately 1/3 of patients do not respond. Infliximab and cyclosporin have been shown to have equivalent efficacy as medical rescue therapies in acute severe ulcerative colitis in randomized controlled trials. And infliximab dose optimization through intensification and interval shortening is increasingly used to treat IBD in the outpatient setting. However, there is no conclusive evidence that such strategies improve clinical response or colectomy-free survival in acute severe ulcerative colitis. Also, the optimal maintenance regime following successful medical rescue after acute severe UC has not been established. Therefore, these investigators wanted to compare the intensified and standard dose infliximab rescue strategies in acute severe ulcerative colitis. This was a multi-center, open-label randomized trial conducted in Australia. Patients admitted with corticosteroid refractory acute severe ulcerative colitis were enrolled. I'm just going to very briefly touch on this flow diagram because it is quite complex. But essentially, patients with acute severe ulcerative colitis who failed steroids were initially randomized in a 1:2 ratio to intensified initial rescue dose, where patients were given infliximab at dose of 10 milligram per kilogram. So that was 1/3 of the patients. 2/3 of the patients underwent a standard initial rescue dose. That's 5 milligram per kilogram. Patients who are allocated the intensified initial rescue dose were put into this intensified induction strategy, where at week 1, they were given infliximab, I apologize, I cannot pronounce this word, infliximab, 10 milligram per kilogram. And then if you were non-responder, they received a salvage dose of infliximab of 10 milligram per kilogram. In patients who were allocated to the standard initial rescue dose of 5 milligram per kilogram, they were further randomized, again in a 1-to-1 randomization, either to an accelerated induction strategy or a standard induction strategy. For accelerated induction strategy, they were given an accelerated reduction of infliximab, 5 milligram per kilogram at week 1 and 3. And if they were non-responders, they also received a salvage infliximab dose at 10 milligram per kilogram. In the standard induction therapy, they received standard induction dose of infliximab, 5 milligram per kilogram at weeks 2 and 6. And if they were clinical non-responders, they received a salvage dose of infliximab of 5 milligram per kilogram. All these 3 groups then entered a exploratory maintenance phase. The primary outcome measure was clinical response by day 7. And these are the baseline characteristics. 46 patients were initially enrolled in the intensified induction group at 10 milligram per kilogram, and then 92 patients were enrolled in the standard induction, standard rescue dose of 5 milligram per kilogram. Then this resulted in 46 patients in the intensified regime. 48 patients were enrolled in the accelerated regime, and then 44 patients were enrolled in the standard regime. These were the median ages across the 3 groups. We're going to focus on this induction strategy randomization groups here at 33, 34, 32 years. The disease duration at screening were 31 years, 36 years, 31 years respectively. Prior therapies included 5 ASAs, steroids, thiopurines. The duration of flare before hospital admission was 6 weeks. 6 weeks, 3 weeks, and 3 weeks. When looking at the primary outcome measure, looking at clinical response by day 7, they found that there was no significant difference between the patients who received Infliximab, rescue dose of 10 milligram per kilogram, versus those who received 5 milligram per kilogram, with patients with clinical response by day 7 of 65% in the 10 milligram group and 61% in the 5 milligram group, with a p-value of 0.62. The authors also looked at the proportion of patients who underwent colectomy and also the rates of serious adverse events, and found that there was no significant difference between the two groups in terms of rates of colectomy by day 7, 30, and 90, and also the rates of serious adverse events by day 7. When looking at outcomes up to 3 months after induction, they found that between the 3 groups, the intensified, accelerated, and standard induction groups, there was no significant difference in clinical response at day 14, clinical remission at 3 months, endoscopic remission at 3 months, steroid-free remission at 3 months, clinical and endoscopic remission at 3 months, rates of colectomy by 1, 3, and 12 months, relapse of ulcerative colitis, and also the withdrawal rates and study completion rates also similar across the 3 groups. The limitations of this study is that this was an open-label design randomized trial with no blinding, which confers to bias, and also the dose duration of oral steroids and thiopurines before study entry were not captured actually, but whether they were exposed to these medications were captured. So in patients with steroid-free refractory acute severe ulcerative colitis, the first dose of 10 milligram per kilogram Infliximab was not superior to 5 milligram per kilogram Infliximab in achieving clinical response by day 7. Intensified, accelerated, and standard induction regimes did not result in a significant difference in clinical response by day 14 or in remission or colectomy rates by month 3. Our next randomized trial was published in Gut. This is a randomized trial comparing hot versus cold snaring EMR for large, flat, non-pedunculated colorectal polyps. We recently reviewed together a multi-center randomized trial on this topic from Europe, and the study is from Michael Burke in Australia. Conventional hot snare EMR of large non-pedunculated polyps greater than 2 centimeters in size is the standard of care therapy. However, hot snare EMR is associated with electrocorder-related complications of delayed bleeding and perforation. Cold snare polypectomy is effective and has been used for treatment of small polyps. Perforation and delayed bleeding are rare with cold snare polypectomy, and therefore use of cold snare for resection of large polyps is an attractive alternative. The aim of this study was to compare the efficacy and safety of cold snare EMR versus conventional hot snare EMR for resection of adenomatous large non-pedunculated colon polyps. This was a randomized trial from Australia at a single tertiary referral centre. Patients with large non-pedunculated colon polyps, 15 to 50 millimeters in size, were randomized in a 1-to-1 ratio to conventional hot snare EMR, and snare tip soft coagulation was performed in this group versus cold snare EMR. The follow-up was at 6 months, at which time the first surveillance colonoscopy was performed, and biopsies of the scar of the at the EMR site was taken, and if the endoscopist saw any residual recurrent adenoma, it was resected at that time. The primary outcome measure was endoscopically visible and or histologically confirmed recurrence at 6 months surveillance colonoscopy. 87 patients were enrolled in the cold snare EMR, 90 patients in the hot snare EMR. As you can see, the majority of the polyps were located in the cecum, followed by ascending and transverse colon. The majority of patients were Paris classification. Majority of the polyps are Paris classification 2A or 2B polyps. That accounted for 95.4% of the polyps in the cold snare EMR group, 94.4% in the hot snare EMR group. Majority of the patients had a granular polyp as opposed to non-granular polyp, and successful EMR was performed in 19.9% in the cold snare EMR group, 100% in the hot snare EMR group. When looking at the resection site after EMR, deep mural injury was observed in hot snare EMR group only, with type 4 noted in 3.3% of the hot snare EMR group. These are the outcome measures. The recurrence rate in the cold snare EMR was 18.4% compared to 1.1% in the hot snare EMR group. And this was statistically significant with p-value of less than 0.001. But if you look at the adverse event rates, significantly lower in the cold snare EMR versus hot snare EMR group. There was no delay perforation in the cold snare EMR group, 1.1% in the delay perforation in the hot snare EMR, and any clinically significant post-EMR bleeding was seen in 7.8% in the hot EMR group versus 1.1% in the cold snare EMR group. However, as you can see, the technical success rate, although similar, they had one patient in whom cold snare EMR was possible, and hot snare EMR was possible or technically successful in all patients. The limitation of this study is that it is conducted at a tertiary referral center, and therefore this confers to limited generalizability of the study results. As you can see, the recurrence rate in the hot snare EMR group was exceedingly low at 1.1%. And generally in randomized trials and prospective studies, the recurrence rate is reported in the range of around 5%. The endoscopists performing surveillance colonoscopies were not blinded to the original EMR technique. Polyps with large 1S component and locations in the ileocecal valve, appendiceal orifice, anorectal junction were excluded from the study, as the investigators felt that bulk lesions were less likely to be transected without electroportary. The take-home points from this randomized trial is that compared to hot snare EMR, cold snare EMR for flat adenomatous large non-pedunculated colon polyps, 15 to 50 millimeters in size, demonstrated superior safety with equivalent technical success. Endoscopic recurrence for cold snare EMR, however, is 18% and remains a significant limitation of this technique. In summary, in Child-Pugh class B and C cirrhosis, patients with high-risk varices, combination of carvedilol and variceal band ligation was more effective than either therapy alone for primary prevention of variceal bleeding, Therefore, combination therapy of portal pressure reduction by carvedilol combined with esophageal variceal ligation is recommended in these patients. In patients with steroid refractory acute severe ulcerative colitis, first dose of 10 mg per kilogram Infliximab was not superior to 5 mg per kilogram in achieving clinical response by day 7. Intensified, accelerated, and standard induction regime did not result in a significant difference in clinical response by day 14 or in remission or colectomy rates by month 3. Compared to hot snare EMR, cold snare EMR for flat adenomatous large non-pedunculated colon polyps, 15 to 50 millimeters in size, demonstrated superior safety with equivalent technical success. However, cold snare EMR is associated with a high recurrence rate of 18%, and this is the significant limitation with the cold snare EMR technique. Thank you so much for joining us this morning. Our next GI Journal Club is December 4th, 2024. Thank you so much. Please have a wonderful and peaceful day, week, and month, and I will see you in December. And for everyone in the United States, happy Thanksgiving. I'll see you in December. Thank you. Bye.